Hello.
Can we start, Gerald?
Yeah, please go.
Good evening, everyone. I'm Dr. Ansuman Saha, Associate Professor in Pediatric Nephrology at IKDRC. I welcome you all to this first of the webinar series on pediatric kidney transplantation. So this will be a 1 hour or more long session. There will be a talk by Dr. Dechup Puliyanda followed by case discussion. So I request all the attendees who have questions, they can type their questions in the YouTube comment box. So we'll be collecting all the questions. Then I will be asking the questions to Dr. Dechup, and the questions will be answered by her. I welcome you all again, and without wasting any time, we will start.
हाँ कराइए अभी मैं थोड़ा बिजी आप कर दीजिए मेरे ये
So we'll start by giving a tribute to late Professor Dr. H.L. Trivedi, who is the founder of IKDRC ITS and Gujarat Unit of Transplantation Sciences at Ahmedabad. And he was a towering figure, visionary figure. He later was awarded with a Padma Shri by President of India at that point of time. Then let me introduce our chairpersons to all of you. Professor Dr. Pankaj R. Saha. He is a senior consultant in nephrology and transplantation currently at Salvi Hospital, Ahmedabad. He was former dean and head of the department nephrology at IKDRC, Ahmedabad. He has outstanding contribution to nephrology with over 40 years of experience. Has overseen over 5,000 kidney transplantation. He has several publications to his credit. Our other chairperson is Professor Dr. Himanshu V. Patel. He is professor and head in Department of Nephrology at IKDRC, ITS, and GUTS. He also has experience of more than 2,500 kidney transplants. Also has several publications to his credit. Now, I will ask Dr. Himanshu to introduce our speaker to the audience. Dr. Himanshu, please.
Good evening, everybody, and welcoming you in the Feast of Knowledge today. It's a great moment for me to introduce an Indian lady who is working in US. Madam Dechup is a professor in pediatric nephrology at Cedars-Sinai Medical Center, California. She did undergraduation in India from Mysore Medical College and further studied in Chicago Rush Medical College, did fellowship in pediatric nephrology and renal transplantation at Children's Hospital, Harvard Medical School, Boston. She has a very great interest in infection in renal transplantation, biomarkers of rejection, management of highly sensitized patient for the transplant, also in ABMR. Of course, being a faculty, she has a lot of publication in her credits. Madam, welcoming you in this feast of knowledge which you are serving us. Thank you, madam. You can start, madam.
Thank you so much for that really nice introduction. Very happy to be with you all this evening, morning for me. I'm going to start screen sharing. Can everybody see my screen? All set?
Yes.
Great. So what I'm trying to accomplish in the next, hopefully 40 minutes is just give you a sense as to how to manage patients who are highly sensitized and successfully give them a kidney transplant. And I am looking forward to a nice discussion and questions at the end of this. So my objectives for today's talk are a little introduction. We'll define what sensitized patients mean. We'll talk about etiologies for sensitization, problems with being sensitized, and the big thing is overcoming barriers to sensitization. Cedars-Sinai, where I work, is what I would call sort of the mecca for highly sensitized patients. I will show you a little bit about what we've done here in the adult world, but I'll focus a lot on our pediatric experience, which I've been doing for the last 21 years. And then we'll talk a little bit about monitoring during the post-transplant period, and we'll conclude. The big crux of my talk will be the pediatric experience. All right, so kidney transplantation is the treatment of choice for patients with end-stage kidney disease, as it's associated with improved patient survival and better quality of life. However, there are several barriers to successful transplant and achieving this. One, as we all know, is the big organ shortage. The second is some of our kids have anatomic barriers to transplant, thrombosed vessels and so on. But the third big one that we are facing are the immunological barriers to transplant. And my focus on today's talk will be to see how we can overcome these immunologic barriers. So at first, we need to have a couple of definitions. One of them is this entity called panel reactive antibodies, or what we would say PRA. So it's a screening mechanism to determine the HLA antibody profile of potential transplant recipients. What is done is that recipient's sera is added to a panel of HLA type cells. And sensitization is expressed as the percentage of the serum reactivity with the total panel. Just to give you an example, if you have 100 cells in a well, and you add the patient's sera to these 100 cells, and then add complement, and you see that there is clumping in like 40 of those 100 cells, then we say that the PRA is 40%. This is to give you a very simple example. What that also means is that that percentage represents the percentage of donors who cannot give a kidney to that recipient. So when you talk about 90% sensitization, it means that 90% of donors from the donor pool are ineligible for that particular candidate. So we also need to define what sensitization means. So like I said, we look at that entity called the PRA, and it's the presence of preformed human leukocyte antigen antibodies. So the general definition that's used is we call patients highly sensitized when their panel reactive antibodies over 30%. And at Cedars, we've used another term called broadly sensitized, because there is a huge difference between being 30% sensitized and being 90% sensitized. So we've used the term broadly sensitized for patients who are over 80% of the panel reactive antibodies. And the etiology of sensitization is if you've had a prior transplant, which is the most common etiology for our kids, previous blood transfusions, that's another huge one for our patients. Pregnancy, of course, in the adult world, And what we are seeing more and more is when patients have infections, especially urinary tract infections, they start to make antibodies. And we've seen patients who have not had a prior transplant, not had a transfusion, and still having significant PRA. So what is the problem with sensitization? Like I said, the higher the percent of sensitization, the less chances you have of getting a kidney from the donor pool. So it's the inability to receive a kidney transplant. And the wait list, if you're on the wait list, it can be from several years to decades. And then if you have somebody who's willing to donate, and you mix their blood with the blood of the recipient, which is called a cross match, they have a very strongly positive cross match against living donors. And of course, they're at very high risk for antibody mediated rejection and graft loss. This is an adult slide, but I just wanted to quickly show you this. When you look at survival on the y-axis and the months on the x-axis, you see that patients who are only on dialysis, their survival goes down pretty quickly. And by about 6 to 7 years, their survival is only about 30%. If they have dialysis or transplantation without sensitization, then first dialysis and then transplantation without desensitization, they still have a lower survival. However, with desensitization treatment for that longer period of time, the survival is very high. So this is a very telling graph. So how do we overcome the barriers to sensitization? There are several ways to do that. One of them is kidney paired exchange. The second one is desensitization, or what we technically call immunomodulation. And the third one is really a combination of both. So kidney paired exchange is where one donor is not compatible with the recipient that they want to give the kidney to. But there's another donor who's also having that same problem with compatibility against their donor. So you kind of swap donors for the recipients to increase the compatibility. And that's done a lot. In fact, one of the longest pairs that have gone on is like 32 donor recipient pairs, where we started with one donor, and then by swapping, we've been able to have the 32 pairs. So 16 patients have been able to be transplanted this way. That's sort of hard to come by. And so the next is immunomodulation or desensitization. And here what we do is you obtain the PRA, like I call panel reactive antibodies. And then if the panel reactive antibody is less than 20% that they've used in this graph, but we use the 30% cutoff, usually no treatment is needed and they can proceed to transplant. If they are between the 20 and 50%, or for us 30 and 50%, we monitor, they have a high rate of post-transplant mortality. So we just monitor for DSAs after transplant and monitor for rejection if they do get a kidney. But the more than 50%, then we consider desensitization. But at our center, desensitization treatment is a standard of care for all patients with PRA greater than 30%. Okay, so this is one of my main slides. It's how can you do immunomodulation in these patients? So this is a cartoon that shows you that the B cell, what I call the bad cell, is the one that makes a lot of antibodies. So preformed antibodies, either because of, again, previous transplant, either because of pregnancy, not in our case, but transfusions, infections. And these antibodies, represented by this Y, which look like antibodies, immediately attack the allograft as soon as it's put into the donor. So what can we do about it? We can do several things. We can first remove the antibodies with plasmapheresis, which is very helpful. We can suppress the antibodies that we've not removed with plasmapheresis by using IVIG. And I'll talk a little more about our protocols later, but this is the, sort of the main thing as to how you can do this. And the third is to prevent antibody formation by targeting these B cells with drugs. So this is really the crux of what immunomodulation is all about. So in terms of talking to you about drugs, I just wanted to introduce this concept of how you recognize what these drugs are about. So When the drugs end with MAB, it stands for monoclonal antibodies. And when the drugs end with MIB, they stand for inhibitors. There are a number of drugs that have been used by different centers in order to immunomodulate. The most important one is the one on the top called rituximab. It is a B-cell monoclonal antibody, so anti-CD20. Its cousin is obinutuzumab or ofatumumab, which is also a CD20 monoclonal antibody. When you have XI in the name of any of these drugs, it means that they're chimeric, which means that they have some sort of animal component to it. But if it has Z in it, it means it's all humanized. So that's another way of recognizing it. So there are a number of drugs: rituximab, obinutuzumab, bortezomib, tocilizumab, daratumumab. All of these are monoclonal antibodies. Eculizumab, and then the C1 esterase inhibitor and belatacept. So all of these drugs have been used by different groups in order to immunomodulate. For us, the most important is sort of the first one, and I'll talk to you about our protocols with using rituximab. The side effects of all these drugs are infections, because they all suppress the B cells, and so you have to really watch out for infections. So one of the other drugs that is sort of the new kid on the block, if you will, is this drug called IDES, which is immunoglobulin G degrading enzyme of Streptococcus pyogenes. This is a very, very new drug that we've used at our hospital in clinical trials. What this drug does is very, very interesting. So the enzyme that's made from Streptococcus pyogenes completely cleaves the IgG molecule at that hinge region. So it separates the FAB from the FC portions and makes it completely inactive. So it cannot do anything. It cannot sort of go and fight against the graft and so on. So just knocks it off completely and makes it inactive. And when you look at HLA antibodies after the use of this drug IDES, it is completely suppressed. So the bottom graph shows you like 1 hour after treatment in blue, where you can't even see the blue. And on the top, it shows you 6 hours after treatment, where you can see all the HLA antibodies are completely abrogated with treatment with IDES. So coming to our protocols, I must say that it has been a very humbling experience to treat these patients, because we've all on a big learning curve. When I probably first started out, we were kind of at the lower portion of the curve right here. And I think right now, I feel like we may have made this leap into, almost stabilization, where we've got our protocols down. But definitely it has been a huge learning curve. And, there have been a number of derangements along the way that we've gone back and looked at, and in retrospect have learned a lot in terms of what we've done and what we could have done better. So what I'm sharing with you is the experience from over 20 years in terms of desensitization. And what we've learned, and this is sort of the general idea of what we've learned, is that one drug alone is not enough. So when people call me and say, well, madam, we've done plasmapheresis, but that's not working. That as you saw in that cartoon slide, one drug is definitely not enough, and the combination works best. And there are several protocols based on combination therapy, and these protocols are still evolving. So because of the huge need to sort of keep track of all these patients, Cedars-Sinai started a transplant immunotherapy program, which we call the TIP program. And it was officially opened on June 28, 2004. And patients are referred from all over the country. Those are highly sensitized and difficult to transplant. And all of these patients, most of them have received a successful transplant. So just to show you a little bit about the Cedars-Sinai experience, again, I said that it was a huge learning curve. We started with only IVIG for this desensitization, and with just only IVIG, we could transplant between 20 and 25% of patients. We realized that alone is not enough. And, we've had so many protocols. The IVIG rituximab protocol was introduced in around 2005. And now we have a whole slew of protocols depending on the sensitization percentage of patients. More recently, we've been doing the tocilizumab. We did do IDIS, but IDIS is on hold right now. And once it becomes available, we will be introducing it back into our protocols. The kidney transplant volume, both adults and pediatrics, we do roughly around 200 to 300 transplants. This is from the year 2002 when we started with all of the desensitization up until 2019. You can see that we've transplanted 1,044 highly sensitized patients to date. This is the the flow chart for management of the highly sensitized patients. I know it's a pretty busy slide. The reference is below here, and it's in the British Medical Bulletin. But basically, what we do is when we recognize patients who have a PRA greater than 30%, we institute our desensitization protocol. These patients are actually presented to the transplant immunotherapy team to actually decide their desensitization protocol, because if they are they are not as highly sensitized, meaning their PRA is not 99%, we typically use IVIG and rituximab. Again, I'll show you our protocols that we do. And then for the diseased donors, we wait for a cross match. I'll also talk to you about the cross match because they do not have a negative cross match, these patients. And when we do transplant them, they get induction with alemtuzumab and then the traditional 3-drug immunosuppression. So one of the important things that I want to talk about is what's called acceptable cross matches. When these patients undergo desensitization, things that you expect to change do not usually change. So one is people expect their PRAs to come significantly down. It actually doesn't. The PRAs might come down just a little bit, but it really doesn't come down to less than 30% values. That's the first thing. The second thing is when you do cross match against the recipient, you will almost always never get a completely negative cross match. What you will get is what's called an acceptable cross match, a cross match that's enough for you to proceed with transplantation using something really strong for induction. What we use here is alemtuzumab. Certain centers have used ATG for induction. So the positive cross match at the time of transplant, we know is associated with poor outcomes. Immunomodulation can reduce and allow antibody titers to a level sufficiently low to create an acceptable cross match that allows transplantation with low risk for ABMR. C1q positive and strong DSAs are very difficult to reduce to acceptable levels. In our center, again, individual centers are different. Look at your own center's cross-matching results. What is a negative cross-match at your center? And then you can decide what the acceptable cross-match needs to be. In our center, a flow cytometric cross-match less than 130 mean channel shifts for B cells and less than 70 for T cells is what's considered negative. So our acceptable cross-match, looking at all of the patients who've developed ABMR right after transplant, what their cross matches used to be. We've retrospectively gone and actually analyzed cross matches. And right now our acceptable cross match for flow is less than 225 mean channel shifts for both T and B cells. So you can see it's almost twice as what it is for a negative cross match. So based on this, when we looked at the rate of ABMR, it was as high as 29% in the very high PRA patients, 99 to 100%, even after desensitization. We think it's because 44% of the patients had a very high cross-match and 80% have had previous transplants and so are highly likely to have memory B cells that resulted in DSA rebound after transplant. But despite having such a high rate of antibody-mediated rejection, our graft survival was greater than 90%. After looking at this, we've actually changed a few things with how we would go forward with transplantation in these patients. We try to not take patients who have DSAs against the donor, especially if it's the DSAs that are strong DSAs. Previously, we were taking them if the cross-match was acceptable, but now we do a virtual cross-match and do not take such donors who have, a strong DSAs against the recipient. So this is the protocol that we use most commonly here at Cedars. We've used this protocol for our pediatric desensitization. So what we do is on week 0, we give them rituximab. Week 2, they get rituximab as well. It's the traditional dose of 375 milligrams per meter squared. A lot of folks have asked us why we should be using this high of a dose, or should we be using a smaller dose. We've sort of stuck with this dose for a long time now. And then we also give high dose IVIG, which is 2 grams per kg, 1 week after rituximab, and then on week 6. And we wait for a deceased donor offer. But here, if we have a living donor, we will do a cross match at this time. And when a suitable donor becomes available, we again perform the cross match. And if the cross match is acceptable, which I told you was less than 225 for both T and B, for flow and CDC, we will, for flow, we will proceed with alemtuzumab induction, and then maintenance immunosuppression with TAC, MMF, and steroids. We have another protocol for patients who do not get a transplant, or we cannot have acceptable cross matches 6 months after the first protocol that we've used. And the protocol number 2 is where we do plasmapheresis ×5 on alternate days, give IVIG and start them on monthly tocilizumab, which is an IL-6 receptor antagonist. And then they keep getting monthly tocilizumab for 6 doses, and then we wait for a suitable offer in these patients. So I'm going to share the pediatric data with you. This was presented as an oral presentation at both IPTA as well as the American Transplant Congress. This was up until December 2019, but since then we've had at least 7 patients whom we've successfully desensitized and gotten a transplant. But the data that I'm presenting to you is the 24 highly sensitized patients. The mean age was 15. Of course, they're adolescents because they've had previous transplants. And the sensitizing events were prior transplants was the majority, blood transfusions, and then some of them had blood transfusions and prior transplants. That's why you see that these numbers don't add up to 100. And then we had 9% of patients who had no sensitizing events but had infections in the past. We had 16% rejection, all but 1 was successfully treated. And our 1-year graft survival was 92%. And the patient who actually passed away because of very severe recurrent FSGS that we really couldn't get under control, and then had a lot of infections. So our patient characteristics, I won't go into details on this, but basically whatever you all see in your patient groups, gender, ethnicity, and causes of ESRD and so on. We've had 8.7% of our patients who've had two transplants prior and came in for their 3rd transplant. So what did we do for what at the time of desensitization? How did it look? We had the PRAs. The peak PRA was around 74%, and then the PRAs decreased in six patients. So, like I said, the PRAs don't decrease hugely with desensitization, but it makes it enough so that they can have acceptable cross matches. So what was our desensitization regimen? 82% of our patients received the traditional IVIG and rituximab. 1 patient, which is 4.3, received plasmapheresis, IVIG, and rituximab, and this was before we actually had tocilizumab come on board. And then 3 patients received plasmapheresis, IVIG, and the tocilizumab, which is also called Actemra, that we use for desensitization. And what is really impressive is that the time from desensitization to transplant was about 9 months, 207 days. So all these patients got the transplant within the year. So in terms of transplant details, only 4 were living donors. And you can see here that the B flow cross match was the mean was 156. Like I said, we take less than 225, and the T flow cross match was 39. And the HLA mismatches were all over the spectrum, really. About 56% of the patients had DSA present at transplant, but these were weak DSAs that we could actually, forgive a little bit and then proceed with transplantation. A very low incidence of developing de novo DSAs. It's almost the same as what you would see in the non-sensitized patients. We had 2 patients who had delayed graft function, and usually they stayed in the hospital for about 7 days. We've had a very long follow-up on these patients. Some of them have had follow-up up to like 9 years now, and they're really doing well. So the creatinine from baseline to 5 years, you can see that the creatinines have remained fairly stable, even up to the 5-year mark. What about rejection and graft loss? We had 14 patients who had rejection. So the incidence of rejection is fairly high, 60.8%. But again, this was also at the time when we took patients, donors who had even a strong DSA against the recipient. We probably wouldn't do it now. But all of these rejection episodes, except for one, were successfully treated. So we also looked at factors predicting risk for antibody-mediated rejection in the highly sensitized patients. This is published in Pediatric Transplantation. The 16 highly sensitized patients were retrospectively reviewed, and we looked at those that had antibody-mediated rejection and compared them to those that did not have antibody-mediated rejection. And what we saw was that the patients who did have antibody-mediated rejection had both higher class 1 and class 2 DSAs at the time of transplant, going into transplant, and therefore they had a high risk for antibody-mediated rejection. Based on this, we actually came up with something called the relative intensity score, where you actually score the antibodies. And what we found was that if the relative intensity score was greater than 17, they were at a high risk. So if they had weak antibodies, we gave them a score of 2. If they had moderate antibodies, moderately strong antibodies, we gave them a score of 5. And the very strong antibodies got a score of 10. So if they had a DSA that was strong and one DSA that was moderate, their score would actually be 15. And these were the patients who were less at risk compared to the patients who had a score of 17 and over. But like I said, we now don't take donors who have strong DSAs to the recipient. So, there are so many new drugs that are coming up, so many new protocols. So this is in a state of constant flux. What I showed you was really, the 2 protocols that we followed, with which we've had quite a good success. We still have 2 patients who are very, very difficult to desensitize, in whom we are waiting for hopefully IDS to be on the market, in the hope that that will help with going through a transplant for those 2 patients. So one of the big things that I always talk about is monitoring patients afterwards. That is one of the most important things that you need to do for all transplant patients. As you know, they constantly need to be monitored for CMV, EBV, polyoma BK. And now we have, a biomarker that we've been using to monitor them for early signs of rejection. And we found this quite useful. And this is also, we've published this in Pediatric Transplantation. So if any of you want, you can look it up. I also wanted to show you, we have this grid that, all of us have in our offices, where we order certain labs on patients at periodic intervals. So there are these general labs and procedures. We do the viral monitoring per protocol here. And for the highly sensitized, we definitely have a very strict protocol that we follow, where we do the DSAs 3 months, 6 months, 9 months, 12 months. And if it's negative, we do them annually. And then we also follow this monitoring protocol with the biomarker, the donor-derived cell-free DNA, which I know is coming to India, so or may already be there by now. So concluding, the management of highly sensitized patients represents one of the greatest challenges to transplant medicine, especially in our cohort of patients. And much progress has been made in removing these immunologic barriers to transplantation through this immunomodulation and desensitization. Our group, amongst others, have developed desensitization protocols resulting in acceptable kidney graft survival, and have shown to offer a survival advantage compared to remaining on dialysis. If you remember the first slide that I show you, where desensitization offers a huge survival advantage. Desensitization of highly sensitized patients awaiting living donor and deceased donor transplants is effective and allows for a significantly greater number of patients to proceed with transplant than would be expected. And then long-term graft and patient survival are comparable to low-risk patients. However, they really need close monitoring to make sure that you catch rejection or any of the infections pretty early. Just wanted to give a shout out to people whom I work with here who are just incredible. The HLA laboratory staff. We have a whole slew of the transplant immunology laboratory. Our renal pathologists are world-class, excellent. And of course, to my mentor, Dr. Stanley Jordan, and the transplant immunotherapy program. But most importantly, I really want to give a shout out to our patients who really trust us with all of these new protocols that come up and who allow us to see what these protocols do. So thank you so much. I think that's probably my last slide. Thanks a lot.
Thank you, Dr. Dechup. It was an excellent presentation. Now I will ask Professor Pankaj to give his comments. Pankaj sir, please.
I will stop screen sharing.
It was really excellent and magnificent presentation, and we really enjoyed. Just I would like to clarify one thing. What is the difference between PRA and CPRA?
Fantastic question. So a PRA is when you just get a standard kit and you look at the percentage of antibodies that these patients have. CPRA is what's called calculated PRA, and that represents the PRA in your own population. Like you can't take the donors from here, all of their lymphocytes, and type it against a recipient in India and talk about a PRA. It's not representative. But a calculated PRA is the antigens that are present in your region where the donor pool is. What is the percentage of PRA for that particular region is what is called calculated PRA.
So, madam, in India, we should have our own CPRA?
Yes, every center has their own CPRA. And your HLA lab will determine that. There is a calculation, but your HLA lab is very familiar with that and they will be able to do that for you.
Thank you, ma'am. Thank you very much, ma'am. Ma'am, I will request Dr. Senas to represent a index case.
Thank you.
Dr. Senas.
Dr. Senas is going to present, no? Hello, Anshuman?
Yes, sir.
Dr. Senas is going to present a case, no?
Right. She's doing it, sir.
Yeah.
Yes, sir, I will be presenting the case. Thank you very much. Kindly confirm if my screen is visible for all.
Visible.
Yes.
Welcome to all the attendees. I will begin my first case. A 10.5-year-old girl who was referred to us in January 2021 for initiation of renal replacement therapy. Pre-referral course-wise, she was apparently asymptomatic till 8 years of age when she presented to a local practitioner with complaint of fever. He was sensible enough to pick up short stature and poor growth along with severe pallor. And the laboratory workup, which was done for fever, incidentally showed deranged renal functions. On further probing, the child was found to have some telltale signs of an underlying chronic condition. She had poor weight and height gain, which was refractory to treatment with several courses of multivitamins and hematinics. Also, some subtle symptoms to point to an underlying tubular origin in form of polyuria, polydipsia, and bedwetting. Lingering symptoms in the form of poor scholastic performance, easy fatigability, and loss of appetite over a few months were superimposed with the fever episode. There were no symptoms to suggest an obvious underlying glomerular or lower urinary tract etiology. No obvious extrarenal symptoms came forward on history. Birth history and development history were normal, and nothing significant showed up on family history either. Relevant examination findings, which were documented at the time of her first presentation, confirmed her short and her severe wasting. Blood pressure was within normal limits. Her general examination revealed pallor. Systemic examination was within normal limits. The laboratory workup did confirm anemia with her hemoglobin at 4 grams per deciliter. Renal functions were deranged, a creatinine of 4.3 with uremia and hyperkalemia, metabolic acidosis. CKD-MBD profile was significantly deranged, and an IPTH of 768 picograms per ml confirmed underlying chronic etiology. Her ultrasound scan revealed renal sizes of approximately 5 centimeters square, which were less than -2 Z-score for her age at 8. This, we concluded our diagnosis as a CKD stage 5 on conservative management. Native kidney disease was attributed to bilateral dysplasia, comorbidities in the form of anemia, CKD-MBD, and metabolic acidosis. For this, she was hospitalized for a duration of 10 days, during which she received 4 units of packed red blood cell transfusion. Metabolic derangements and other issues were medically addressed. She was on a monthly follow-up with the local pediatric nephrologist, and as her renal functions progressively worsened, she was counseled to initiate RRT. That is how she ultimately landed with us. Briefly, her course at IKDRC, she was first seen by us in January 2021, and after confirming our diagnosis, in view of solute and fluid overload, she was advised to start dialysis immediately. Ultimate need for transplant was clearly discussed with the family. Since there were no living donors feasible on account of socioeconomic grounds, family opted for initiation of dialysis and registration under SOTO for cadaveric kidney transplantation. These are her RRT details. She was initiated on hemodialysis, which was carried on for a period of around 3.5 months, during which both her right as well as left IJVs were spent in view of catheter-related bloodstream infections and partial thrombus in the left side. Failing maintenance hemodialysis through the neck vessels, she was switched over to CAPD, which lasted for around 5 months, during which her course was complicated with back-to-back infections. A third refractory episode of peritonitis mandated removal of the catheter. And finally, we ended up using the right brachiobasilic fistula, which was very precariously salvaged by a fistuloplasty in view of primary failure on account of stenosis. That serves as her current access. So despite the SOTO protocol of registration 3 months into initiation of renal replacement therapy, on account of legal and documentation delays, she was registered almost 11 months after initiation of RRT on 22nd of December 2021. So her course on dialysis was complicated by 1 episode of emergency admission for management of a hypertensive crisis in the form of pulmonary edema, in addition to the recurrent infections and vascular access related complications. Sensitization events we could identify from her course so far were recurrent episodes of infection and the blood transfusion, 4 units of PCV, which were received during her initial treatment by the primary physician. We do not know if they were irradiated blood products or any leukocyte filters were used at that time. As a part of her cadaveric transplantation registration, immunological workup, blood group was B positive. HLA typing, both by molecular and serology, were done for class 1, A, B, and C loci, and class 2, DR and DQ. Her PRA results were 12% for class 1 and a whooping 93% for class 2, as Madam has enlightened us, broadly sensitized. Her multiple antigen bead assay was positive for all 3, class 1, class 2, and MIG-A. So we followed it up with a single antigen bead assay. She had 1 class 1 anti-HLA antibody against class B with a maximum MFI of 1054. And the class 2 was all over the place with a total of 38 anti-HLA antibodies with a maximum MFI of 12,459, predominantly in the 5,000 to 9,999 MFI range. So far, she has been offered kidneys twice, almost 2 months apart. As per our institution's policy, we do a virtual cross-match first, and if that stands positive, physical cross-match is deferred. So unfortunately for our kid, both the times her virtual cross-match was positive and she did not stand a chance to come forward for a physical cross-match, rejected both episodes. So madam, how should we proceed in this case?
Shanaz, can you hear me?
Yes, ma'am, I can hear you. So, madam, what would be her sensitization risk stratification with her broadly sensitized 93% PRA of class 2? How should we proceed further?
Yeah, I mean, this is the kind of patients that we see. Obviously, like you said, she is definitely broadly sensitized. Her CPRA, her PRA, I mean, that's you don't report the CPRA, but it's pretty much the same. Is pretty high, over 80%. I would suggest that your desensitization approach be what we would have done here, which is plasmapheresis times 5, followed by IVIG, and 2 weeks later rituximab. That would be our desensitization approach to begin with. After you do that, in a month, you can repeat the single antigen assay, and then you can talk to your HLA lab about looking at, what happens to your single antigen beads, and if you can remove some of those unacceptable antigens, if they have lowered in their intensity, because if you leave them there, you'll always get a virtual cross-match that's positive. But if you take them off, then at least your virtual cross-match will be less likely to be positive, and you can do the flow cross-match and the CDC cross-match. So you have to repeat the single antigen beads and see if you can remove some of the single antigens that have lowered in intensity with their MFI ranges, so that you can, see if your virtual cross matches will come back, looking much better, so that you can proceed with the flow cross match.
बहुत अच्छा discussion है.
So then looking at CDC and the flow cutoffs post desensitization, you have to look at what is your current CDC and flow cutoffs, for your non-highly sensitized patients, and then look at what is an acceptable, flow cutoff for your desensitized patients. Usually it's about, you can accept up to 1.5 times of your normal, but you'll have to look at it in your center as to what your cutoffs can be, depending on what your cutoff is for non-sensitized patients. And then what would be the cutoff MFI to call the patient for physical cross-match when DSA is present? That's a very, very important question. I think I alluded to that, when I was talking above. I think that your MFI cutoff, if it goes from strong to moderate, you're much more likely to be able to, remove that as an unacceptable antigen and then proceed with cross-match if their MFIs are in the moderate range for you. And I'm not talking about specific MFIs, because what is moderate for you may not be moderate for us, etc. So you had given the MFI cutoff. So if they go from being really strong down to moderate, you can actually, consider doing a physical cross match to that donor. Does that answer your question, Shanaz?
Yes, ma'am. Thank you.
That is the. Yeah.
Anshuman?
Can I chip in? Yeah.
Yes.
So that was exactly what is happening. Like we have one patient, he is very broadly sensitized, like more than 90% of PRA. We have done one session of desensitization, like Plex and rituximab. But after that also he's got 2 calls, and every time he's having cross match positive, like 30%, 40% of CDC cross match. And in fact, Dr. Himanshu is in charge of calling patients. So he's after me that why you are calling this patient and you are denying other patient who can get a fair chance of getting the kidney, because since these patients are broadly sensitized, they are high on the list and they get calls every time. So that was the question, like what should be the cutoff MFI when you know that the cross match will be definitely very high, very positive, and you will just not call the patient for a physical cross match.
Right. So I think if you have a strong, a strong DSA, so the MFIs are, I think what you said was greater than 10,000, then you obviously will not call this patient. But if the DSA have reduced to a moderate intensity MFI, you can really call this patient for a physical cross match. But the most important thing, Anshuman, is to decide what will be your center's cutoff for flow cross match. I mean, CDC is important, but as you know, CDC gives you a lot of IgM antibodies as well, which may not be all that important, but a flow cross match, will really give you the indication as to whether you can proceed with transplant. If you're looking at flow cross matches to be completely negative, just like non-sensitized patients, it's very difficult to get that. So you need to put sort of a cutoff for your flow cross matches to what you would accept it, and then proceed with transplantation using something very strong for induction immunosuppression. So that's where the problem is. Like, most centers would look for a negative cross match, but like I'm telling you, it's almost impossible to get a negative cross match after desensitization, because these patients have such strong, they have a lot of strong antibodies. So you have to look at an acceptable cross match. And the MFI, for us, the MFI cutoffs would be moderate when we would bring the patient for a physical cross match. Does that make sense?
Yeah. So your cutoff for B cell is 225. That's what I...
Both T and B cells is 225. When our negative cross match is less than 130 and less than 70. So like I said, it's about 2 times what our negative cross match cutoffs would be is what it is for an acceptable cross match.
So do you do lymphocyte cross match or CDC cross match also at the time of transplant?
Yes, we do both. Very rarely do we get, CDC positive and flow negative, but when we get CDC positive and flow negatives, we really think of IgM antibodies that are present, because as you know, with cross matches is a whole big talk in and of itself, but CDC cross matches recognize both IgM and IgG, but the flow cross matches are more the IgG that's present, so which is more important.
Right. And what are the effects of rituximab and IVIG in the cross match?
Yes, so that is very important. So rituximab can cause a false positive cross match because of something called a prozoning effect. So you have to use pronase, which will abrogate that rituximab false positivity. So when you have treated the patient with rituximab, always do a cross match with pronase in it so that it removes that rituximab effect and you get a true cross match value. So that is very, very important. I'm sure your HLA lab knows this, and I'm sure they do it as well, Anshuman.
Yeah. Can we proceed for the second case?
Yes, sir. So coming to case 2, an 11-year-old male child diagnosed with CKD stage 5 on maintenance hemodialysis since 23rd of December 2021, that is around 3 months back. The family was counseled for kidney transplantation and mother came forward as a willing donor. This in brief is the recipient evaluation. Blood group is B positive. The urology workup on the ultrasound scan, we have bilateral small-sized kidneys at less than -2Z scores with CMD lost. So our native kidney disease diagnosis is bilateral dysplastic kidneys. The MCUG rules out any lower urinary tract abnormality. The bladder has regular outline and there is no reflux. Systemic evaluation does not find anything abnormal. The donor details, blood group is B positive, so we have a ABO compatible transplant here. The mother is 35 years old, lean and built with a BMI of 20.15 kilograms per meter square. No comorbidities like diabetes, mellitus, hypertension, ischemic heart disease, or obesity here. Surgical and obstetric history is not significant. Donor evaluation in brief, a creatinine of 0.5 milligrams per deciliter with a ultrasound scan suggestive of renal sizes 10.5 and 10.3, confirmed on CT renal angio. Right side kidney has a single artery and dual vein, whereas left kidney has a single renal artery and a single venous drainage. DTPA scan confirms a total GFR of 109 ml per minute per meter square with a split of 55 and 54 on the right and left respectively. A thorough systemic evaluation and relevant fitness from all the departments has been obtained for her. The recipient sensitizing events that we have identified are 1 unit of non-irradiated PCV was transfused 1.5 years back by a local pediatrician. No recent infections reported. With this background, we went ahead with a immunological workup. The HLA typing was done, and we found a haplomatch as expected for the mother and the son. The cross match was favorable with LCM of less than 5% and AAG less than 5% as well. Flow cross match was negative for T as well as B cell. The screening multiple antigen bead assay was however positive for class 1 as well as class 2, which prompted us to go ahead and do the single antigen bead assay. We found a single donor specific antibody against DQB1 in a MFI range of 4,687. So, madam, is this DSA significant or not?
So Shehnaz, remind me again, the MFI of 4,000 is, where does it fall in your range of MFIs? So what is considered
Moderate.
Yeah, what's considered moderate and strong?
Madam, anything more than 1,000, like in the range of 1,000 to 5,000 is our first law, that is mild. 5,000 to 10,000 is moderate, and more than that is like severe.
So okay,
strong.
Great.
But this is like borderline, ma'am, not, and these are.
Sorry, Shehnaz, are you breaking up?
Ma'am, am I audible now?
Yes,
Madam, so this is
you are.
falling in the borderline range, closer to the 5,000. So,
Yeah. You know,
so moderate is the strength which we've concluded.
Right. So this is fairly straightforward, I would say, because this is a very weak DSA against donor. But you know, and you know, since the cross matches were so beautiful, I think that you can safely proceed. But if you want to be a little cautious, you could use a dose of IVIG and rituximab going into transplant. So maybe 2 weeks before, you could use give him a dose of IVIG, and at the time of transplant, give him rituximab and then proceed with transplant. I think he'll do fine. You can definitely proceed with the same donor. No, I don't think you should consider change of donors, because this is a really weak DSA, and you know, you're less likely to get into trouble with a weak DSA. But like I said again, just to be on the safe side, you know, you can just give 1 dose of IVIG and Ritux. No need for anything else.
Madam, what is the definition of a strong DSA? Is it based solely on the MFIs, or do we have to consider the class, the type of the DSA, as well as the C1q binding and the other characteristics as well?
Very, very interesting question. In fact, I'm going to be speaking next month at the Pediatric Academic Societies meeting on DSAs. So this is a very timely question. So yeah, a lot of questions about DSAs. You know, at this point, we are not doing C1q binding because if you have a strong DSA, and again, strong, moderate, and weak depend on your center's MFI cutoffs. Since you told me that in your center, 1,000 to 5,000 is considered weak, and 5,000 to 10,000 is considered moderate, and anything over 10,000 is considered strong, I'm going to speak in that language. So anything over 10,000, so a strong MFI is almost always associated with C1q binding. They're all C1q binding antibodies, and they are all very detrimental antibodies. So anything strong MFI, we would not consider at all. And then whether class 1 is, less dangerous than class 2, in general, we say that the class 2 antibodies are much more deleterious to the graft compared to class 1 antibodies. And then amongst the class 2, the DQ, the DR, the DQ, and the DP obviously are the ones that we would really consider, as more deleterious than others, the other ones. So I think that, in this case, since you have a weak DSA, and you can easily sort of, we give, like I said, we give the relative intensity score points, right? So if you were to give points, I told you anything over than 17 points is very highly likely to cause AMR. In this case, because it's just a weak DSA, this would be just 2 points. So 2 points would be completely fine with much less risk for antibody-mediated rejection. So I think you can safely proceed with this transplant, but with a dose of IVIG and rituximab in order to make sure that these antibodies don't creep up after transplant. So giving them 1 dose of IVIG and rituximab and proceeding with your regular transplant route. I think you guys do like ATG and same, TAC, CellCept, prednisone would be fine. Yeah. This is a lot of our donor recipient pairs, just so you know. So yeah, these are the what we call the easy ones.
Madam, hello, am I audible?
Yes, you are.
So, madam, from our previous experience, 3 of our previous transplant, when we had DSA, single DSA of around 5,000 MFI, but all of them had early ABMR, like within 3 months, they had ABMR. And so it was picked up, timely treated, and they recovered also. But from that experience, for these patients, we were little reluctant to go ahead with the same donor, specifically when child had a class 2 DSA. So, so that was why we have kept this case to discuss about change of donor.
Right. So, but what did you pre-treat those patients with IVIG and Ritux or no?
So one of them was cadaver. So we had IVIG to that child, but he had ABMR within 4 weeks, and we had not given rituximab to that child before ABMR. But as a part of treatment of ABMR, he received rituximab. And to other children, we have not done anything, not even IVIG or rituximab.
You know what? Try doing IVIG and rituximab and see, what happens. I'm not saying that they will not have ABMR, but even if they do have mild ABMR, it's very easily treatable.
Okay.
What is it to say that the other donor that you get will not have DSAs? And this is such a pristine donor, This is
that's true, ma'am.
creatinine of 0.5, such a great HLA match, I would go with this donor, but with a background of IVIG and Ritux.
Okay.
So what will be the protocol of giving IVIG and rituximab?
So that's great. So I would give IVIG 2 weeks before transplant, and rituximab, you can give it the day before transplant, like going into transplant and then giving ATG. That is fine too. Like maybe a day before you can give rituximab, and then the next day, go ahead with transplant with ATG.
Madam, currently we are facing a lot of crisis because of this availability of thymoglobulin. Then also should we go ahead and do with the same protocol with grapholon?
Yeah, we've talked about this. I think Anshuman mentioned grapholon, which we don't get here actually. Grapholon is more of a humanized version,
Yeah.
which kind of may be better actually than thymoglobulin. I'm sure your adults have a lot of experience with grapholon. So I think, you know, at least in the studies that I have done, I think it's very safe to proceed with grapholon.
Okay. Okay.
Dr. Himanshu sir, can you just give a comment on this?
For grapholon.
Yeah.
Madam, we have given one dissertation to our student. But basically, we are using a grapholon in a low risk patient who have actually a haplomatch to start with.
Mm-hmm.
But other centers are doing well with patient who have no haplomatch, zero match. So it's still we have a dilemma whether we can use the grapholon in our sensitized patient or not.
So why is there an issue with using it in sensitized patients? So what is, how does it compare with thymoglobulin, ATG?
So madam, the dose we don't know actually. The company is proposing as a 10 milligram per kg. And the ATG we are using in India is almost 3 milligram per kg. So we are not able to judge the what is the dose we should use. So initially we have started with the low risk patient. Now gradually we are moving on the cadaver transplant also. In the cadaver also we are facing some rejection, but not in a great number. So slowly we are increasing our dose also. Initially we started with 4 milligram per kg grapholon, then we switch over to 8 milligram. Now we are on the 8 milligram almost. So 8 milligram per kg dose is in our patient is, I think it's okay. So we are evaluating our dose.
Right.
So the issue is that there is hardly any head-to-head comparison.
Correct.
And the problem of non-availability of this thymoglobulin is quite recent. So actually we don't have experience and we don't have evidence also about how to go about it. We have used in very few patients, like maybe hardly one living donor. Unfortunately, she had UTI 1 week after transplant and she developed rejection.
Oh God.
Recently, we have, I think yesterday only we had 2 cadaver transplant and we have used grapholon. The other issue with grapholon is that it decreases, it suppresses the counts like anything.
Yeah. I mean, if it does that, that means the dosage that you're using is too high.
So we have last time we had used 6 milligram per kg. This time we are planning to give 8 milligram per kg, but today's counts are quite low, so we have hold today. So tomorrow again we'll decide. So we gave, the child's weight was 33 kg and we gave 100 mg yesterday. The plan was to give 250 milligrams, 8 milligram per kg. So there is a lot of confusion and we don't know many things. So that's the issue that is happening.
So you know what, unless you know a stable dose of grapholon to use, I would not use it in the sensitized patients.
In that scenario, you are using alemtuzumab. So I think availability is not an issue. So can we use that? We have never used.
You can use alemtuzumab. It's a very nice drug to use. It does cause significant leukopenia, just like ATG, but the amount of leukopenia that it causes is similar. You know, so if you can get alemtuzumab, I definitely can give you a protocol and the doses. And we've been using alemtuzumab as a subcutaneous dose, not IV, at our center, and it causes you know, fairly prolonged leukopenia that lasts for about 6 months to a year. And otherwise, it's pretty comparable, actually. So I can share our protocol if you ever happen to get alemtuzumab.
It is available.
What about the risk of infection?
So we have published this in terms of risk of infection, comparing alemtuzumab with IL-2, which is a very sort of, for want of a better word, weak induction immunosuppressant like basiliximab. And we did not find higher rates of infection with alemtuzumab compared to the basiliximab. So the risk of infection is pretty much the same. You will just have to monitor these patients. If they are donor positive, recipient negative, they will get CMV or EBV, but you just have to monitor for it. It's pretty much the same. They do have significant leukopenia though. Even then, the risk of infection is pretty much the same compared to basiliximab. It's published if you guys want to look that up.
Okay.
Okay.
You can proceed next.
Yeah, definitely consider alemtuzumab much more than grapholon because there are so many unknowns with dosing of grapholon.
Madam, our last slide, considering a hypothetical situation where we have a very highly sensitized patient with no other options to wait or to choose for an alternate donor. So in that situation, madam, if we have to proceed with the same living donor, then what would be the choice of desensitization and how should we proceed?
This is the donor with the weak DSA, right?
Yes, madam, but if at all the sensitization risk is high, the RIS, as you had pointed out, in a hypothetical situation, if it is more than 17 and there is no other alternate donor available, then what should we do? And also the child cannot be waitlisted on the Forever program.
Right. I would definitely do desensitization with we talked about, if they are broadly sensitized, plasmapheresis, IVIG, and rituximab. Repeat the single antigen bead assay about a month after desensitization. The cutoff that we would use is if they are moderate, then you can sort of proceed with transplantation. And for us, the induction immunosuppression would be alemtuzumab. But again, if you can get ATG that has been used across the country for desensitization for induction for highly sensitized patients, I think that's fine. And then post-transplant immunosuppression, we would do the traditional 3 drugs, Prograf, Celsep, Prednisone, as your usual protocol. In fact, we don't use higher doses of higher levels of Prograf. We use it as the same as the non-sensitized patients. And post-transplant, we do monitor DSAs very closely. We do it at 3 months, 6 months, and then at a year. If they have DSAs, then we monitor them more frequently. But if they are DSA negative post-transplant, then we pretty much do it every year after the first year. The post-transplant AMR risk is present. I'd say that in the range of 15 to 20%. But if you recognize it early and you treat it, they have very good long-term graft survival, just like your non-sensitized patients. In fact, their AMR, I think, is easier to treat than the AMR that you find in the non-sensitized patients. The late AMRs are very, very difficult to treat. So these patients, since you are really closely monitoring them for AMRs, you pick them up pretty quickly, and you are, a lot of times very successful turning them around.
So
Madam, I think at your center for DSA survey, please go ahead, sir.
No, go ahead.
Madam, I was asking about the DSA surveillance. So do you use the AlloSure for DSA surveillance?
The AlloSure is a very different thing that we use to monitor. If we do have patients who have DSAs, let me backtrack. All our patients get AlloSure monitoring at this time because we found that a lot of patients who are DSA negative and they have a high AlloSure, they all have ABMRs on biopsy. So the AlloSures help us pick up these patients who have ABMRs, whether they have DSAs or not. So, and then, if they don't have DSAs and they have ABMR, we look for non-HLA antibodies like AT1R and stuff like that. But these patients definitely have all of the features of ABMR on histology. So we do AlloSure testing more frequently than we would do DSA surveillance.
I have
Okay,
one
ma'am.
question,
Thank you.
ma'am.
Sure.
We didn't discuss about post-transplant, second transplant or re-transplant patients who are highly sensitized. So my question is, what can we do to decrease sensitization in these patients? What would be the immunosuppression? Is there a role of nephrectomy?
Yes, very, very nice, interesting question. So again, it's published, Anshuman, but the most important thing to do is to try not to do a nephrectomy if you can. Because what we found is in patients who've had nephrectomy, they lose sort of, in my words, the sump that holds the antibodies, and their antibody titers go way up. So if you can avoid nephrectomy of the first transplant, that probably is better. Second, do not discontinue immunosuppression. Leave them on low dose immunosuppression. Some centers choose to leave them on like tacrolimus with very low doses, like 2 to 4 or that kind of levels of tacrolimus, with a very small amount of steroids, like 5 milligrams, or the younger patients 3 milligrams of steroids, and take them off of CellCept perhaps. But leaving them on immunosuppression, not doing a nephrectomy, trying to avoid blood transfusions, obviously, are the ones that will really help you with your second transplant. And we've seen that in a lot of our kids. After knowing what we know, we really, truly, leave them on a little immunosuppression and not do nephrectomy. And these patients, you'll see, even after one transplant, their PRAs are like 10 or 20, which is really, really nice going into the second transplant. Yeah.
Now I would request Dr. Pankaj to, if he has any question or any comments. I think Dr. Pankaj is not there. Dr. Himanshu, sir, Himanshu sir.
Yeah.
If you have any question or comments, sir, here to make.
Madam, one question. If we consider a DSA positive, suppose patient has a 2 or 3 DSA, which are the more than 5,000. Instead of 1 DSA or 2 DSA, multiple DSA, what should we do? Whether we should call them for the cadaver transplant or not?
Ma'am, you have to unmute yourself.
My dogs were barking. That's where we introduced this concept of relative intensity score. So if you have multiple DSAs against donor, you give points to the DSAs. So if they are weak DSAs, they get 2 points. If they are moderate DSAs, they get 5 points. And if they are strong DSAs, they get 10 points. So if you have, let's say, 4 DSAs and all 4 are strong, obviously they get 40 points in that case, and you would definitely not consider that, going forward with that. But you have, let's say, 2 weak DSAs, against the donor, the points would be like 4 points. And those are the donors that you can actually consider. So giving them points is pretty useful, but definitely after knowing what we know, we would not consider a donor who has strong DSAs against recipient, even if it's 1.
Thank you.
So we'll take few questions from the audience. Dr. Priya Pais is asking, so she has commented, great talk, Dr. Dechup. Have you found a higher risk of PTLD with the use of desensitization protocols?
Hi, Priya, it's good to see you on the board here. We have, knock on wood, I never say never, but we have not seen a single case of PTLD after our desensitization protocols. There are 2 things with respect to that have probably helped us. Number 1, most of our recipients coming up for a second transplant have EBV seroconverted if they were EBV naive for the first transplant. So a lot of them had EBV infections with the first transplant. They're all seropositive. So going into the second transplant, these patients are EBV donor recipient positive. So that makes them at lesser risk. The second, and I think the most important reason, is use of rituximab. We have seen that patients get desensitization with rituximab, and even if they are EBV seronaive going into their second transplant, we've probably eliminated some of their EBV stores with the use of rituximab, and so they are much less likely to have overt EBV viremia compared to our non-highly sensitized patients who did not get rituximab, who are at higher risk, and who are seronaive going into transplant. So we have not seen a single case of PTLD in our highly sensitized patients. But do we monitor? Yes, we check EBV on a regular basis for them.
Ma'am, I would like to ask, like, what would be the infection? What infections do you see after your desensitization protocols after rituximab?
Yeah. So the infections that we see are your traditional infections, especially depending on their sero-negative status. So in the second transplant, if they are getting a CMV positive kidney and they have been CMV negative, we definitely see CMV in them. The same thing with EBV. We do see polyoma BK, but it's not higher than what we would have seen in a non-sensitized patients. We do see the same incidence of urinary tract infections as our non-sensitized patients. Now, rituximab is known to cause some degree of hypogammaglobulinemia, and there are some unique infections that you can get with the use of rituximab that I've actually seen when I take care of the adult patients. Like I've seen one patient get nocardiosis, another patient get aspergillosis. Whether it's entirely because of rituximab or all of rituximab and alemtuzumab combination is unsure. But that's why when we treat these patients with rituximab, for whatever reason, we put them on prophylactic antibiotics with cotrimoxazole because of the risk of infections. So we've not seen any overly unusual infections in our highly sensitized patients compared to our non-sensitized patients.
Okay, Dr. Somil he has commented, lovely talk, Dr. Dechup. What is the cutoff of DSA which you choose to deny transplant? The same question I think I asked.
Yeah, oh, definitely strong DSA, we would completely not even proceed. But after desensitization, if those strong DSAs are reduced in MFI to moderate, then you can consider proceeding under cover of some strong induction immunosuppression like ATG and alemtuzumab.
Dr. Apurva is asking, is it necessary to monitor CD19 level after giving rituximab before the second dose?
We don't monitor CD19 levels because we give 2 doses. In fact, I know a lot of centers do CD19 monitoring, but we have not found it overly useful to do CD19 monitoring because we give the 2 doses. What we do monitor is the IgG levels going forward because a lot of these patients are hypogammaglobulinemic. However, we're giving them IVIG at such high doses, so that sort of negates the hypogamma that we see with rituximab. But we don't monitor CD19 doses unless we want to give them at some point a 3rd dose of rituximab after transplant. Let's just say, they got 2 doses of rituximab and then they went into transplant, and then within 2 or 3 months they have AMR, and we want to treat them with IVIG and Ritux. So that would be the 3rd dose of Ritux within the 6-month period. That time we would do a CD19 monitoring and see, whether it's too suppressed that it's, it is dicey to use the rituximab, or we can go forward and use the rituximab. But that's the only time. We don't monitor otherwise.
Again, Dr. Somil is asking about fluconazole prophylaxis. So,
go ahead, Anshuman.
So Dr. Somil is asking about fluconazole prophylaxis in these patients.
Yes, all our patients get 1 month of fluconazole orally. They get 6 months of valganciclovir regardless of their CMV and EBV serostatus, and they get 6 months of cotrimoxazole because they've gotten rituximab. So that's our protocol. We give them 6 months of valganciclovir, 6 months of cotrimoxazole, and 1 month of fluconazole.
Okay.
Yeah, and something that's unique here, which I don't know whether the situation would be similar there, is we have, we have areas that are endemic for coccidioidomycosis. There are certain parts of the country here that are endemic for, coccidioidomycosis. Those patients are on lifelong fluconazole. We don't take them off of it. But this is only certain parts of the country. Like, we get patients from all over the country. And so, the prophylaxis is, especially for fungal prophylaxis, is determined by where they are coming from. And so there are certain patients who are on lifelong fluconazole for that. So you'll have to consider what's endemic in your part and see if you need to extend prophylaxis. But traditionally, our prophylaxis for fungus is 1 month.
Okay, there is no more question from the audiences.
I want to ask one question to Madam. So, Madam, you mentioned in your presentation that when first protocol, that is plasma exchange IVIG and rituximab. So, how long do we need to wait for the match or a compatible donor to meet the criteria? And if we are not able to get adequate donor till that time, then what should be our next step?
Yeah, very nice. See, that's exactly the situation that we see here. Here, because it takes a long time for us to get I think the wait list is pretty long here. Southern California has the highest wait list in the country. So we wait a very long time for donors. So if they are on the cadaver wait list, for us, after the first desensitization, we wait for 6 months. Okay. And if they don't get a compatible donor within the 6 months, compatible donor meaning with an acceptable cross match within 6 months, we go to the tier 2 of desensitization. And so we've had some of our patients have had 4 tiers of desensitization. So they go through tier 1, they don't get it for 6 months because they're so highly sensitized, 99.9% CPRAs. Then we do tier 2 desensitization, and then we go to tier 3. So we've had patients who've had multiple rounds of desensitization before they get a transplant. But these are fewer though. You saw that when I showed you, 86% of our patients got a transplant with the first round of desensitization itself. So yeah, but so you wait for 6 months.
Yeah, so madam, when we go to a second cycle or a third cycle, then do they have more chances of infection because their cumulative immunosuppression will be more, because these are people are second transplant patients?
Right. So you know what, that is really a very interesting question, because that's exactly what we looked at, when we looked at our low risk patients given basiliximab and our highly sensitized patients who were given several rounds of desensitization and then given alemtuzumab, right? So we saw no difference, but I really think that's because we give IVIG, which is passive antibodies against infection. I mean, you treat a lot of your viral infections with IVIG, and you're giving them IVIG because it's a fantastic drug. It's an immunomodulator, yet it also takes care of viral infections. So I think that's why you see lesser chance of infections with these patients.
Okay, yes. So I think we...
Madam, it's an excellent. Yeah, Senath, yeah.
Madam, have you ever come across any patient who is very intolerant to IVIG, develops a lot of side effects with IVIG, like raise in ICP or we had a child who even had 6 cranial nerve palsy and a lot of CNS side effects. And so how do you deal with it? A brand change didn't do much good to our patient.
What did not do much?
Change in the brand of IVIG is what was suggested, considering that.
So here are a few strategies that we've used. Again, this is side effects of IVIG and management, again, has been published by our center. But one of the important things that we do is we split dose IVIG, because you're giving 2 grams per kilo. what we found is initially when we did our desensitization, we gave all 2 grams in one day. We saw a lot of side effects, including, like what you mentioned, pseudotumor cerebri, really bad headaches, and really hemolysis. We saw a ton of patients having really bad hemolysis, requiring transfusions, which is completely, negates the reason for desensitization. So then after that, we started using, of course, we use only a particular brand of IVIG, which is less, has got less osmotic load compared to others, because a lot of the side effects are because of the very high osmotic load that you have with IVIG and of course volume. So we use the one that has the least osmotic load compared to IVIGs, and obviously, completely sucrose free, which you all know. And then we do split dose IVIG. So we give it either in 2 or 3 doses even. So we might give like 0.75 milligrams per kilogram on the first day, and then a couple of days later, another 0.75, and a couple of days later to complete the 2 grams, we give like a 0.5, grams per kg of IVIG. So split dose IVIG really, really helps. And the second thing that helps is pre-medication with higher than your usual doses of Solumedrol. So I'm not sure what you use for pre-medication, how much Solumedrol you use for pre-medication. Do you use 40 or 60? Or 1 per kilo? What do you use?
We use hydrocortisone.
Oh, okay. Why do you use hydrocortisone? It's kind of a weak steroid.
Yeah, but for rituximab also, like that's our protocol. We have used hydrocortisone and promethazine, that is Avil.
Okay. Yeah, the Avil is the Benadryl equivalent, to reduce reactions. But
Yes,
I think that in the patients whom you're having allergic reactions to IVIG, I would use methylprednisone and not hydrocortisone, which is a much more stronger steroid, which will negate some of your side effects. So split dose using, methylprednisone, and probably, like 1 per kilo of methylprednisone as a pre-medication, along with your Avil, would be the way to go for these patients. Yeah.
Thank you, ma'am.
Very, very
It was an
nice
excellent.
question.
Yeah, it was an excellent presentation, and whenever we listen to you, it's kind of invigorating for us, and it gives a lot of energy to go ahead. And it was really a very nice presentation, madam, and we look forward to many more talks from you. And we are closely collaborating with you also, and you are so helpful. Middle of the night also taking calls. So now I would request Dr. Kinnari to give vote of thanks and conclude this session.
So thank you all the attendees for being patient and for the lecture. And I would also like to thank our chairperson, Dr. Himanshu Patel sir and Dr. Pankaj Shah sir for their time. And thanks to madam, as Anshuman Bhai has already said, that making such a difficult topic and you made it so easy for us, and so approachable, and even in midnight also you have been always there for us, for our patients. Thank you so much. And though our first aim should be not to prevent desensitization, but however, if we reach to the platform where desensitization is necessary, you have always been there with us, madam. Thank you so much.
Wonderful. I hope to see you all soon. I know that there's a conference coming up, so yeah, hopefully we'll see you all.
Yeah, this year it is transplant as a theme.
Are you coming to Mumbai?
I want to. Yeah, Dr. Uma Ali has actually invited me. Hopefully it'll all fall into place. I'm scared to say yes because of all the COVID situation. So barring everything, maybe yes. Yeah. Love
okay. Thank you, ma'am. Thank you.
Thanks a lot.
Please come and visit us in Ahmedabad.
Of course. Yes.